thank you very much for inviting me and for the introduction. I'm going to be talking about blood clots in pregnancy today. This is an overview of what I'm going to talk about. We'll start off by looking at VTE in pregnancy in numbers, look at why VTE is increased in pregnancy. I'm going to talk about VTE risk assessment in pregnancy, how we go about diagnosing VTE in pregnancy, treatment, and some of the ensuing delivery dilemmas, as well as postnatal VTE risk assessment and treatment, and the added challenge of COVID. And I'm just going to finish by talking about some of the organisational challenges that we face looking after pregnant women in large organisations. And first of all, I just thought I'd tell you about a tricky case that I've been dealing with in the last week, which highlights some of the dilemmas around anticoagulation and VTE treatment in pregnancy. This lady, when I got involved last week, was 34 weeks pregnant. She'd had 2 previous vaginal deliveries. Unfortunately, she'd had premature rupture of membranes. That's PROM, we love an acronym in obstetrics, at 23 weeks gestation, meaning that she was at high risk of going into labour early and could essentially go into labour at any time. She had COVID last year and had a COVID-related DVT. And then she went on to get a recurrent DVT in her current pregnancy. So she was on therapeutic molecular weight heparin, BD dosage. And when I saw her last week, she was an inpatient with a severe asthma exacerbation. So she has really very severe asthma, very poor lung function tests. And then I got a phone call that she was having regular contractions. So that presents a number of challenges. Clearly risk of imminent delivery. She's on full therapeutic anticoagulation. She's premature. How are we going to manage those competing priorities? So I'll do my talk and I'll tell you the end of the story at the end. So why is it important for us to be very aware about VTE in pregnancy? Well, there's a 10-fold increase in the incidence of VTE in pregnancy. We know that the 7-day period after the baby's born is the highest risk time. That's because the body is trying to stop bleeding, bleeding that's been caused by delivery. But we also know that the VTE risk stays elevated for 6 weeks postnatally. Venous thromboembolism is the leading indirect cause of maternal death. So all maternal deaths in this country are reported to the confidential inquiry, which used to be known as CMACE, but is now known as EMBRACE. And we've been collecting data on maternal deaths for about 50 years now, which is very useful for looking at trends. Deaths are divided into direct or indirect causes. So direct maternal death causes are things that are directly related to the pregnancy, like preeclampsia or postpartum hemorrhage, whereas indirect causes can be connected but are not directly attributable to the pregnancy. And VT is the leading cause of indirect maternal death. And as you can see, the data is always presented every 3 years. So you can see the most recent data. A significant number of mums do still die every year of venous thromboembolism despite our best efforts. So why is the risk of blood clots increased in pregnancy? Well, there's 3 reasons which make up part of Virchow's triad. The first one is that the blood is hypercoagulable in pregnancy. So women have stickier blood, and that's because of changes in the blood. We know that factors 1, 5, 7, 8, 9, 10 and 12 and von Willebrand factor as well all increase. There's a fall in protein S, and there's a suppression of fibrinolysis as well. Secondly, there's a mechanical compression of the pelvic veins by the baby. So we have venous stasis in the lower limbs, and also the very act of a baby passing through the pelvis, and that's whether it's delivered vaginally or by cesarean section, does cause a degree of endothelial damage to the pelvic vessels, and those 3 factors all increase the risk of VTE in pregnancy. Venous thromboembolism risk assessment in pregnancy is a huge part of what we do in maternity services. I think we've definitely developed a better awareness of this over the last 20 years. And we reassess women's venous thromboembolism risk at booking, every time they get admitted to hospital, after delivery, and at every postnatal hospital admission. So I'll start off by talking about antenatal VT risk assessment. So this is a points-based system, and risk factors can be pre-existing. I'm just going to show you our form that we use here in Sheffield, but it will be mirrored in your own organisations because it's just taken directly from the Royal College of Obs and Gynae Green Top guidance. So the risk factors could be pre-existing, so things like previous VTE, background of a thrombophilia, family history, age, smoking, BMI, parity, so 3 or more previous babies. There could be obstetric-specific risk factors like preeclampsia in the current pregnancy, or twins, or assisted conception, or they could be transient risk factors like hyperemesis, long distance travel, current systemic infection. So we use this scoring system, we tick all that apply, and this gives us a numerical score. So as you can see from this table here, if the score is 4 or more, then we recommend that women start low molecular weight heparin from the first trimester all the way through pregnancy and for 6 weeks postnatally. If the score is 3, then we recommend starting low molecular weight heparin at 28 weeks gestation, so that women are getting the prophylaxis for the 3rd trimester, which is the highest risk period of the pregnancy other than that first 7 days postnatally, mainly because the mechanical pressure of the baby is increasing and stasis in the pelvic and leg bones. If the score is 2 or less, then no thromboprophylaxis is required, but of course reassessment may be required if the woman presents as an inpatient during a pregnancy or if circumstances change. In pregnancy, low molecular weight heparin is a treatment of choice. It's a big molecule, and it doesn't cross the placenta, and we know that it's safe in pregnancy. In a very small number of cases, we do use warfarin, like people who are really high risk, like people with mechanical heart valves. But the concern with warfarin is the embryological congenital malformations it can cause if it's used between weeks 6 and 12 of pregnancy. So it's very rare that we use it. And no acts are contraindicated in pregnancy and breastfeeding. So we dose according to the booking weight. Some trusts or some organisations do reweigh women as they go through pregnancy, but the RCAG says that we can use booking weight for dosage, and that's what we need to use in our organisation. I wanted to speak a little bit about some of the challenges of diagnosing VTE in pregnancy. Many of our normal systems that we use and normal protocols can't be used in pregnancy, and that means that we end up with a lower threshold usually for investigation. So D-dimer is not useful in pregnancy, and we know that it increases as pregnancy progresses. So most women will have a positive D-dimer by around term. And there's also, we know it's a very good negative predictive test, don't we? But that's not necessarily applicable in pregnancy. So D-dimer is not useful. Also, the Wells score is not validated in pregnancy. There's been some ongoing work at the moment looking at modified scoring predictive systems, and they look very promising, and that hopefully will be useful in the future, but they're still being validated, so on routinely being incorporated into clinical practice at the moment. So as a result, we have a low threshold for investigating in pregnancy. It's important that we offer women the same imaging as non-pregnant patients. I think understandably so, there's often reticence to do different investigations. So obviously doing a Doppler is absolutely fine if there's a query about a DVT. In women in whom we're querying a PE, we would normally do Dopplers first if they've got any DVT symptoms. But if not, they would require the normal workup that we would normally do for a PE patient. So starting off with a chest x-ray, which is very low risk really, and very low risk of radiation, and we shield the baby as well if a woman needs either a chest x-ray or a CTPA. So we would start off with the chest x-ray and then consider either a CTPA or a VQ. There's pros and cons to both of those. So CT is useful if the chest x-ray is abnormal, because obviously it can pick up other pathology as well, like infection, consolidation. It's more readily available than VQ. And there is a lower radiation risk to the baby, but a higher radiation risk to the woman's own breast tissue, which can increase her lifetime risk of breast cancer. On the flip side, a VQ scan delivers lower radiation to the breast tissue, but slightly higher radiation to the baby. So it's really important that we discuss these very small risks with women when we're talking about CTPA and VQ scanning. I always find it a very difficult conversation, to be honest, because we are talking about very small risks. The risk of radiation to the fetus is the risk of childhood cancer, but that risk has been quoted as 1 in 170,000. We quote it on our information leaflet as less than the risk of being killed in a road traffic accident. So it's a very small risk, but it's obviously a very emotive topic. So we have a consent form that we go through with women, which has to be completed before a woman goes for either a CTPA or a VQ scan. One of the difficulties with the diagnosis of VT in pregnancy is that there's a big crossover between normal pregnancy symptoms and symptoms of DVT and PE. So ankle swelling, so common in pregnancy. This is where looking at the clinical presentation really helps. Obviously, normal ankle swelling of pregnancy would usually be bilateral. Up to 90% of women will experience breathlessness, particularly towards the end of their pregnancy. Again, it's all in the history, you know. Has it been a slow onset of the breathlessness? Does it settle at rest versus it's a sudden onset and they're all the time? But that is one of the difficulties of diagnosing PE in pregnancy. So when we've proven a DVT or a PE, we usually recommend twice daily low molecular weight heparin. And the duration of treatment depends on the gestation and diagnosis, but would normally reflect the normal guidelines about treatment. Depending on when the woman has the VT episode in her pregnancy, sometimes she will have had enough of a period of therapeutic anticoagulation to be able to reduce the low molecular weight heparin down to prophylactic prior to delivery. Then we come to planning delivery. So it's very important that women who have a VT in pregnancy are seen in an MDT setting, ideally in a haematology antenatal clinic with a haematologist and an obstetrician, both providing input. Some of the dilemmas that we have relate to our delivery planning. So it's very important to have a plan in place prior to the end of pregnancy, and hopefully in place early. So if the woman presents with any complications or preterm labour, there's a delivery plan in place. One of the big questions we have is whether to induce people who are on therapeutic anticoagulation or not. So we know that prophylactic anticoagulation does not increase the risk of postpartum hemorrhage, but therapeutic anticoagulation certainly does. So really we need women to be off therapeutic anticoagulation for the shortest amount of time possible to allow delivery and reduce the risk of postpartum bleeding. But we all know that birth is a very unpredictable business, and the best chance of having a straightforward, quick labour and delivery is to go into labour spontaneously. Often when we interfere with the process, i.e. inducing people, we prolong the whole process, and that in itself prolongs the time that people are off anticoagulation. So it can have its pros and cons really, and we often debate about whether we should induce people or not if they're on therapeutic anticoagulation. Historically we always have, but we're starting to move, we in Sheffield are starting to move away from it now because there's the induction system's under a lot of pressure, and there's often a lot of people waiting a while to be induced, and it's just actually the whole situation even further. It's very important for us to minimise the time off anticoagulation. Some women who are very high risk, so for example people who've had very recent VTE, people who have got very high risk conditions like antithrombin deficiency or antiphospholipid syndrome with previous VTE. Sometimes we use unfractionated heparin in those patients, so we can use that throughout The benefit of that obviously being that you can turn it off and reverse it more easily than low molecular weight heparin. So we can use it in labour and turn it off usually a few hours before delivery. The difficulty comes in predicting when people are going to deliver. First-time mums often progress at a regular rate of about a centimetre per hour. People who've had babies before can be 3 centimetres 1 minute and pushing the baby out the next minute. So it can be very difficult to get the timing right, even with unfractionated heparin. I will say as well that people who have VT very close to term, that presents an additional dilemma, and we would usually have MDT discussions between haematology, obstetrics, and also vascular radiology about whether placing an IVC filter would reduce the risk of embolization of the clot. There are also anaesthetic considerations. So if somebody's on therapeutic anticoagulation, then they can't have either an epidural or a spinal anaesthetic in case they need a cesarean for 24 hours after the last dose of therapeutic low molecular weight heparin. It's 12 hours after a prophylactic dose of low molecular weight heparin. So we also have to take that into account when we're doing our delivery planning. Postnatally, low molecular weight heparin and warfarin are both safe to use in breastfeeding, and women should be given a choice about which they would prefer if they require thromboprophylaxis. Warfarin does pass into the breast milk, but at very small levels, so it's not thought to be dangerous to the baby. NOACs are contraindicated in breastfeeding, but if a woman has made the decision to bottle feed, then they can be offered and used in the postnatal period. So the risk assessment is slightly different in the postnatal period. Instead of it being a numerical score, people are assessed as low risk, moderate risk, or high risk. I'll just show you our form that we use here in Sheffield. Again, this just mirrors the RCOG green top guidance on the subject. So people who are in the high risk category, people who've had previous VTE, anyone who's had antenatal dalteparin would usually be in this category. People with raised BMI who've had a cesarean section, or people with high risk thrombophilias. In the intermediate category, we have decided in Sheffield that anyone who's had a cesarean section gets 10 days postnatal prophylactic dalteparin. The RCOG guidance is slightly different. It says that if people have no other risk factors after an elective cesarean section, they don't necessarily need it, but we felt very uncomfortable about people having a cesarean section and not having low molecular weight heparin. So there are other things that you can see there. If people have to go to theatre after delivery, for example, for removal of placenta, or if they've got a raised BMI and they've had a vaginal delivery, they would go into that intermediate risk. And then the risk factors at the bottom, some of those are pre-existing risk factors, mirroring the antenatal risk assessment form. And some of them are extra risk factors that people pick up at delivery, for example, preterm birth, stillbirth, having a complicated instrumental delivery, having a prolonged labour, or having a postpartum hemorrhage. So if you score 2 or more out of those risk factors there, then you automatically go into the intermediate or the moderate risk category. And people who've got a lot of risk factors, so more than 3, or if they're persisting risk factors, then sometimes we would consider extending their prophylaxis to 6 weeks postnatally. So just to go over that: low risk, no thromboprophylaxis needed; moderate risk, low molecular weight heparin and TEDs for 10 days; and high risk, low molecular weight heparin and TEDs for 6 weeks. So COVID has certainly been a complicating factor. We know that VT is more prevalent in pregnancy, but COVID has increased those risks further. So COVID infection in a pregnant woman should trigger a VT risk reassessment. All inpatient pregnant women with COVID should be given low molecular weight heparin. In the antenatal scoring system, COVID is classed as a transient risk factor. So if the woman's got a background score of 2 and then gets COVID, then that would tip her into having a score of 3 or more, and she would be given low molecular weight heparin for 7 to 14 days. Postnatally, women are considered to be moderate risk if they have a COVID infection, so we're given 10 days of low molecular weight heparin. Also very important to consider higher doses in women who've got severe complications, either intermediate or therapeutic, if it's felt to be required. Just a quick word about some of the organisational challenges of looking after pregnant women in big organisations. I think we're very familiar with our risk assessment forms in maternity because we're filling them all out all the time, but pregnant women often attend other parts of the hospital, like ED, orthopaedics, general surgery, and understandably there's less familiarity with pregnancy-specific VT risk assessments, and it may be that the relevant paperwork is not available, so it's really important that there's a knowledge about these pregnancy-specific VT risk assessment tools, and that they're easy to get hold of, downloadable off the internet, or available on all wards where pregnant women could be seen. I think people's concerns about imaging are well founded. Well, they're very understandable, but we must investigate pregnant women as thoroughly as non-pregnant women, and as long as women are fully informed about the small risks associated with imaging, the majority of them are willing to have the test, because they have being labelled as having a PE or a DVT in pregnancy has got big implications for delivery in the postnatal period. So it's really important that we get the right diagnosis. And I think communication between departments is also crucial. So again, if a woman is seen in another part of the organisation that is and then diagnosed with a VT, that is communicated to the obstetric team, so that the woman could be referred appropriately to haematology obstetric services and a delivery plan made. So I'll just tell you the end of the story about my my lady. So she was contracting, but she wasn't in labour. It was felt that we'd got to the end of the road with her really poor lung function, and that she needed delivery because the pressure of the baby was putting too much pressure on her lungs, and she was really struggling. So a decision was made for early delivery. After discussion with her and the wider team, it was elected to go for a planned cesarean section, because it was felt that she wouldn't have the lung capacity to push. That made it slightly easier in terms of managing her anticoagulation. So we stopped her therapeutic low molecular weight heparin for 24 hours. She had a cesarean section performed under a spinal anaesthetic, which was crucial because a general anaesthetic would have been really, really dangerous for her with her lungs. She had a little boy who was delivered in good condition. You can't put pregnant women back on their therapeutic anticoagulation straight away because of the risk of bleeding. So she had prophylactic low molecular weight heparin for 2 days, and then went back onto her therapeutic low molecular weight heparin. And she's doing really well now. So in conclusion, there's an increased risk of VT in pregnancy and the postnatal period, particularly that first 7 days after delivery. Risk assessment's really important. 90% of women with a PE in pregnancy have identifiable risk factors. If in doubt, seek advice from maternity staff who will be very familiar with VT risk assessment in pregnancy. Have a low threshold for investigation if pregnant women present with signs and symptoms of DVT and PE, and importantly, don't delay imaging in these women.
Fantastic.
Yeah, that's a picture of an amazing sculpture at Yorkshire Sculpture Park, which is close to my house, of a huge pregnant woman, the Damien Hirst sculpture. Happy to answer questions.
Daily reminder for you then, Tessa, of what you do. You just can't escape it even when you leave the hospital. Thanks so much. That was so informative, Tessa. And I think that you highlighted the need for I'm just aware that a lot of the clinicians on the webinar today may not work in obstetrics, but I think, like you say, pregnant patients get to sort of be admitted to all parts of the hospital, don't they? And obviously the community as well. So it is important that we've all got an understanding of the risk of VT in pregnancy. We've got a few questions coming in, if that's okay. Somebody would like to know why some trusts offer stockings in maternity and some don't, if you are aware of that.
Some trusts offer them routinely, do you mean?
I think that's probably what's meant.
We offer them postnatally to women who we're giving thromboprophylaxis to. There isn't, I'm not aware of any recommendation to offer them to all pregnant women, regardless of VT risk assessment in the antenatal period. People that we think are particularly high risk, or particularly people who've had previous VTE, we sometimes offer full length stockings too. But yeah, I don't think there's any national guidance recommending that. Plus, they're quite difficult to wear, really, aren't they, if you don't absolutely have to wear them?
Yeah, they are, and hot as well.
Yeah, very.
How soon after delivery can a woman be switched to once daily? Would she be re-weighed and the new weight used? I'm guessing this is for somebody who's going to need a treatment dose, anticoagulation.
So we would usually give prophylactic treatment for 2 to 3 days. I mean, it depends on clinical assessment. If they've had a section, is there any concerns about intra-abdominal bleeding? What's their lochia and their PV loss like? Is it heavy? Is it moderate? Is it minimal? So that's kind of a clinical decision, but usually we would restart on day 2 to 3, and we often restart on once daily dosing. If you're going to start warfarin, then we really should wait till about day 5 because of the risk of secondary postpartum hemorrhage.
Yeah. And for low mercury heparin, do you base that on their new weight postpartum?
It's a really good question. We just use booking weight, but you'll probably absolutely right that you'll get a more accurate weight if you reweigh. Although there's you've got a lot of fluid shifts in those first few days after pregnancy. I always think it's slightly unfair, weighing people immediately after they've delivered. Their weight will probably then be different a week down the line. But if some people certainly do put a lot of weight on during pregnancy, and it's appropriate to reassess them.
Yeah. Somebody has asked if all patients who are on DOACs prior to pregnancy, perhaps for AF, do they all get switched to low mercury heparin in pregnancy?
So I would say that there is not that. I feel that there's not that many, because I also look after the cardiac clinic. I don't feel like there's a lot of people on long-term anticoagulation in this age group for cardiac reasons, and we usually would reassess the indication if they became pregnant. We don't tell people, DOACs aren't so strongly contraindicated that we tell people they must switch to low mercury heparin before getting pregnant. And obviously lots of pregnancies are unplanned, but we just advise people to switch as soon as they can, as soon as they know they're pregnant. But yes, we'd review the indication essentially and think about whether they need to low mercury heparin throughout their pregnancy.
Great. Do you monitor anti-10A levels for ladies on therapeutic low mercury heparin? Yes,
we do. Well, it depends. There's certain groups of patients that we definitely do. So mechanical valve patients, we monitor anti-10A levels obsessively, sometimes weekly, peaks and troughs, because we need a really tight window, anticoagulation window. People with high risk thrombophilias like antiphospholipid syndrome or antithrombin deficiency, we do anti-10A monitoring. Wouldn't routinely do it in other patients unless they were at extremes of BMI generally.
Yeah. If it's okay with you, I think we've got time for one last question. Patients who are diagnosed with antiphospholipid syndrome in pregnancy, do you tend to keep them on long-term anticoagulation?
I think it's very much depends on what kind of antiphospholipid syndrome they've got, whether it's VTE related. We have a whole group of patients who've got pregnancy, who've got antiphospholipid syndrome on the pregnancy criteria, and their VTE risk is much lower, obviously, than the group of patients who have it on the VTE criteria. Clearly, pregnancy is a provocation; it's a provoking factor for a VTE. So, I mean, it would be up to the haematologist in the end, but I wouldn't say that they all end up on lifelong anticoagulation, no.
Yeah, and what we tend to do as well is do another panel of antiphospholipid syndrome tests after the pregnancy.
Absolutely, you need to do those outside of pregnancy, sure. Yeah.
Tessa, you've been wonderful. Thank you so much for your time. Wonderful talk, and thanks very much for answering all of our questions today. We really appreciate it.